You're now in this office. This is the first time I've ever been here. Where am I? Can you just tell me what's going on here? I walk up the stairs. There's a baby bassinet over there. There's secretaries in the other office. What's going on here?
So, as I stated, we grew really quickly. We don't have any babies or dogs in the office today.
That'd be okay if there were.
Yeah.
You know, I like babies.
As you can tell, we have a few.
Right. Work with everyone.
I know.
Okay, Michelle. This series is Cape Codder, so can you just tell us where you were born?
I was actually born in Natick, Massachusetts.
Okay. And where did you grow up?
I grew up there until I was 10, and then I lived in Somerville until I graduated high school.
What type of childhood was that? Did you go to public schools or?
I did go to public schools. I did go to parochial school in the city when we moved into the city, and then went back to public high school for the last 2 years. So,
okay.
So typical middle class upbringing.
And then after that, what happened?
Actually, I moved to Florida
okay.
when I turned 18 to get away from the cold.
Yeah.
Stayed down there for on and off about 13 years, and then came back here to be closer to the family.
Okay. And when did you come to the Cape?
So I want to say it was about 25 years ago. To be near my niece and my nephew as they grew up. So, and I haven't left since. Gotten pretty involved in community activities and events and whatnot, and have made a home here for myself. So.
And all these 25 years, were you doing nursing or?
No, I did a variety of other work. My primary love and joy work was actually coaching. I coached in the community for 20 plus years. Recently retired from coaching high school. I coached at both Pope John and Sturgis West.
Okay.
And I ran my own softball program for about 20 years.
So it was softball. You're doing currently right here at Hyannis.
So I guess sort of the way I explain it is just to kind of actually back it up to where I first started as a nurse. My first job as a nurse was at the Duffy Health Center, which primarily focuses on homeless health care. I fell in love with the population, fell in love with community nursing. My job was actually running the addiction program. I was with them for 5 years. Very proud to say that program has done the community a lot of good. It's still operating, and Dr. Lisa was an amazing person to work with. I went on to a couple of other community health centers on Cape to help them get their addiction programs up and running, and in the meantime started doing psychiatric home care as a part-time job.
Okay.
Fell in love with this and really decided I wanted to do this more as my full-time job, and transitioned over to that probably about 5 years ago. Ended up having the opportunity to work with the owner here at Relief, which was originally in Boston, a smaller agency, to create more of a case management team approach towards what we do out in the community as psychiatric nurses. And in the last 3.5, almost 4 years now, we have developed therapy programs to go along with the nursing and home health aides. What started off with myself and one patient has grown to be almost 140 employees and almost 550 patients across 3 counties. So it's been a huge task. I'm not actually out in the community doing nursing, but I'm creating teams and still coaching, and we've created an opportunity for people to work and actually know and feel that they're making a difference every day. And
let's back up a little bit. When you were at Duffy, and you were a psychiatric nurse, or at that point, or just a general nurse?
I was actually a certified addiction registered nurse. I was specifically focused on patients who had heroin addiction, and they would come into treatment outpatient at our clinic. I would see them weekly, and then as I graduated through the program, they would be seen less often, but they were involved with behavioral health and also were seen medically, and then we had case management for them over there. So that whole team approach really made a difference. It was very rewarding.
In general, I know you can't go into specifics, but can you just give us an idea? Not many people are familiar with that program over there. What would an average day look like? For
the nurse that did the job, we would see patients just on the regular, like the other providers. Most of the appointments, certainly we're trying to get an update on how the patient's life has gone on since the last time we saw them, make sure, you know, they're safe and they're stable, they're not in crisis, assess how the medications are working for them. We do work with medication-assisted treatment, so that was part of their treatment, but also making sure that their, you know, behavioral health work was being attended to and made a priority. You know, a lot of the work that we did over there was, it's almost subliminal. You know, I tell a lot of people that my last visit on Friday nights was actually a young kid that used to come in and I used to help him read. And that made more of a difference in that kid's life than any medication we could have given him. You know, he's gone on to have a great job, and, you know, things are really going well. And that's the sort of experience that I want to teach other nurses and other people who work for us to have, is that you have to think beyond, you know, the job, think outside the box to really make a difference.
Right, so it's just not the medicine.
No.
The medicine's just part of it.
It's a part of it. It's a tool.
Yeah.
You know, it's that human contact and teaching life skills and teaching coping skills and being a part of something bigger than yourself, and understanding that we're all attached to this community and we all have the ability to negatively or positively impact our community. So that's really, you know, the direction that I like to
Can you
coach
just take
from.
us through maybe you know, like a patient that would typically make contact over there at Duffy? How would that go?
Sure. Over at Duffy, their main focus is homeless health care. They are actually embedded out in the community. They have a lot of other programs. I'm sure you could contact them to get more details. They work with people that are truly homeless, that are what they try to do, get them in from the streets. So they have one of those programs. They're in contact and they provide medical care over at the shelter. But right in the clinic, people coming in for treatment generally are not immediately in crisis. They've either heard about the program and have failed a bunch of other different ways, or haven't quite gotten to the point of really being in a dire situation, and so they know that there's an opportunity to turn their life around, and that's usually what drives those specific patients into programs like Duffy and Outer Cape, and, you know, all the community health centers on the Cape have the same type of program now.
So you're at Duffy, and I'm sure you had success stories there, and
Yeah.
are you able to share with us one of the success in general? Because I know you gotta.
Well, that young man I just mentioned, I think to me was probably one of my biggest success stories, but I have actually quite a few. I have actually been to weddings and christenings of some of my patients' new families, and it's been a joy, you know, and to see people actually realize that they are just like everybody else. You know, their addiction does not define them, and to know that they can always go back to the basics again and relearn, or you know, reach out to the people that help them along the way. You know, it's really amazing to watch.
So when you're in the process with someone like that young man that you helped do the reading and stuff like that, was that a turning point in his recovery?
I think it was. He had certainly had it a little harder to begin with for 6 or 8 months, and then as he settled in, and obviously we built trust, you know, he admitted that the hardest struggle he had was to get a real job because he couldn't read, you know. And so we made it a focus of that being what we were going to do every week. And it was life-changing for him, and, you know, you get that kind of wow moment when things kind of click, and
he trusted you at that point.
Exactly, and that's really what it is. I think that we all have to learn to trust one another, and with everyone's good intentions, we can all accomplish a lot.
So that's the major component really here, from where, you know,
Absolutely.
the trust.
Absolutely.
Yeah. Establishing that rapport and the trust. So that's a great story. So you did that earlier on. Now how long ago was that when you?
I started in 2007, so from 2007 to 2012 I was with Duffy. I was with Outer Cape, helping them for a couple of years, and then I went on to Harbor Community Health Center for 3 years, and then I fell into this, and this has just been the perfect transition for me to go back to coaching, but also still continue to make a difference. I think coaching is just in my nature, and I brought an enhancement to my nursing because of my coaching background. You know, really, you know, we talk about meeting patients where they're at, but it translates inside of coaching as well, as everybody learns differently and sees differently and hears differently and reacts differently, and if you can try to understand your student, so to speak, you can understand the path that's going to help them towards success easier instead of putting square pegs through round holes. I know that's not the best way to do things.
So these lessons that you learn from care and meeting patients where they're at really apply across the whole spectrum, the whole board, really.
Absolutely.
When you deal with people, right?
Absolutely, it should.
Yeah.
It should.
Yeah. There's so were a lot of your clients in the past, I would assume some of them were homeless, and
yeah, a lot of them were homeless, or what people don't realize is the couch surfing or whatever, that truly is considered homeless. So
yeah.
And a large majority of them at the time were 18 to 25-year-olds, which was pretty amazing, those statistics. So a lot of them had burned bridges with families, or maybe were in sober homes or whatnot, but a large number were homeless.
And how do you get over that?
Well, again, it's just taking the approach that I do from a trying to understand first what's important, what's the immediate thing they need the most help with, because that usually kind of brings down the anxiety of it, and then really trying to create like almost a work list. You're talking about housing, so roof over your head. I mean, do you have income? Do you have food? And do you have social contacts that are meaningful?
Right.
Do you belong to an organization that gives you support? And that really can be any organization that gives you support. There's no one-way road that it takes. And so just kind of through an investigation, but with soft hands, really trying to find out really what their intentions are too. Sometimes they really didn't realize they weren't just coming in for a pill, they were coming in for much more, or at least they were going to get a lot more. And
soft hands.
Yeah.
Is that an approach that that's like, that sounds self-explanatory.
Sure. I mean, there were times certainly when, you had to lay down rules or whatever, but try to avoid that at most.
Sidestep those.
Yeah.
Right. Did you find that at first some people were very maybe oppositional to what you were doing, or just maybe hard to reach?
I think when I first started doing that work, I took a very different approach, not ever having worked in that field prior. And when I kind of sort of stopped myself and reanalyzed my successes up to that point, I wanted to take that coaching and bring it into my nursing, because I felt I had almost experienced the same thing like that in the ball field in the past, not having been the greatest coach I could have been, really learning how to use softer hands and use a quieter voice, and really try to meet each player where they're at. I really felt like, okay, we're talking about meeting each patient where they're at, let's try a different approach. And that's really, for me, in my own profession, what has been the most successful for me.
Yeah. Is softer hands, is that also a softball term?
It is, actually.
I mean, actually, when you're, right?
It is.
You got to feel the ball. You can't have rigid hands.
Yeah,
right?
no, not at all.
That's excellent. I like it. Yeah. And can you give us an example of softer hands? Can you think of anything offhand? I
can tell you that there were frequent times when our patients would what we call relapse, but having built strong relationships with them, they would immediately come in and let me know. And when I first started doing the work, I was reactionary, and of course then they react to you. As my approach changed and softened, by making it more of a conversation, not a confrontation, not making them feel like they were wrong, or let's use all of the other negative labels that we want to put on people with addiction challenges.
No judgment.
No judgment, and that's really was what the turn was in these conversations, which allowed them to then try to peel the onion of trying to figure out, well, how did maybe that come about? What was the trigger for that? And can we back up and try to find an alternate choice? Instead of going to a party, go to the gym first, or avoid to avoid those triggers and whatnot. And by using softer hands and a softer approach, those conversations became more possible.
Again, this is a key element to, you just can't throw like Suboxone at a person. It sounds like this is like has to be part of it.
Well, in my opinion, I think it's for my career, it's been the most successful for me.
So in this issue, I mean, how long would it take somebody? I mean, do you find? I mean, I have a little bit of experience in this issue myself. I mean, I see people go to these rehabs for like just 30 days and then they're back out. You know, is that enough time? Or, I mean, how long does this process take with, you know, to get somebody with soft hands, you know?
Well, I think that the combinations all have to be right, and I don't think there's any right answer for any one person. There's no perfect med or perfect treatment that fits everybody. That's the same, I think, with anything. If you look at diabetes, I always used to throw back the question of, well, would you send a diabetic to be on insulin for just 30 days? There's a whole life learning of habits that person has created, no different than the addiction piece. And peeling that onion and learning new habits doesn't happen in 30 days.
Right.
It doesn't happen with a month worth of insulin or a month's worth of Suboxone. It happens over time. You know, and you know, diabetics can be in recovery, just like an asthmatic can be in recovery. I think the biggest thing for me that was just glaring is the amount of negativity we would throw at this disease process. I know. I think that our attitude, our public attitude, if it would change, would also help heal and provide a better, healthier way for people to heal.
So after Duffy, you're now in this office. This is the first time I've ever been here. Where am I? Can you just tell me what's going on here? I walk up the stairs. There's a baby bassinet over there. There's secretaries in the other office. What's going on here?
So, as I stated, we grew really quickly. We have an amazing group of people that work here, and no different than anything else I've ever done. I wanted to create a team and understand that everybody who's on the team is going to be different and have different needs, and so we meet everybody where they're at. I have no problem with people need to bring their kids to work or their pets to work. You know, got to make sure that everybody's on a leash and whatnot. Yeah. But
no alligators.
Yeah, we do flexible hours. We recognize everybody for their own set of gifts that they bring to the table, and I think that we've created a really great work environment here.
So what does this agency do? First of all, can you just tell us what it's called?
It's called Relief Home Health Services.
Relief. All right. And so now just tell us what that does for your clients.
So we work collaboratively with all of the other organizations in the community that work with our patients. So the psychiatrists, the inpatient psych unit at the hospital, the crisis center, the shelters, the transitional houses like Champ House, Homeless Not Hopeless. So what we do is try to keep people stable in the environment, reduce ER visits, reduce hospitalizations, really try to help them either connect to the case management they need in order to improve their life status or help them get housing, or we can do some of that case management. We collaborate with all of their providers to make sure that their medical care is actually all on the same page, so to speak. Sometimes there's doctor's offices that don't know that one patient is actually being seen at a different doctor's office, and they might have two different med lists, so our nurses really coordinate a lot of that kind of care as well. For the sober homes that we see, they tend to have a lot of patients that are really complex medically and have the comorbidity of psychiatric diagnoses. And so our nurses can go in there and help stabilize, but we also manage medications, and in doing so we lock them up and we keep them safe from other people in the home, whether, you know, accidentally taking something, sharing, obviously diversion we want to cut down, but we also want to keep not just our patient safe, but everyone around them as well. So there's an approach to doing that. So we communicate with the doctors quite frequently. We have team meetings here. We have grown a therapies department here, so we have physical therapy, occupational therapy, speech therapy, and we now have home health aides. And we all operate from a psychiatric perspective. So our occupational therapists aren't just working on, you know, getting that hand to move better, or, you know, traveling up and down stairs safer. It's the anxiety that the patient experiences thinking about going up and down the stairs is a coping skill that the occupational therapist works on, so they'll be more willing to try. You know, we work with a lot of hoarders, a lot of people with social agoraphobia, and those are some bigger challenges that we have that certainly as a team approach, it has really helped to elevate the quality of those people's lives. And so it takes a lot of effort and a lot of oversight, but I believe that we've made a huge difference in the community. We participate in the Cape and Islands Behavioral Health Coalition. We coordinate with NAMI on a lot of things. We recently started a pediatric division, and out of that has come an obvious red flag of we need to do more for our pediatrics, probably not just here on Cape, but that's where we're focusing this program at. A lot more support for kids with depression and anxiety. There's a lot of transgender youth that don't have support around the Cape. We've actually initiated what's called a virtual hangout for them, where we have staff that will, allow patients into this virtual group, and it's more of a support group than anything else.
Sounds like a wide range of people that you see. Is there one unique thing that gets them to your doorstep, that gets them in here, or is it just in general?
I would say, and I would pride myself on the fact that we've made a difference in this community, and we have committed ourselves to continuing to do so, and I believe that the people that we are connected with realize and recognize that, and so we try to not ever say no. We try to think outside the box and do what we can to, help a physician with a really complex patient, or get a homeless person seen even though they might not have a physical address. So we try to think outside the box, and I think that and in our proven reputation of really taking care of these people and reducing the hospitalizations and the ER visits, I think that really drives a lot more referrals in our direction.
So who does the referrals usually? Is it the patient, or is it sometimes the patient, or is it both? Or?
Yeah, so anybody can refer. A person can refer themselves. A family member can refer. The most of the referrals we get are from the doctor's offices or the hospital themselves. But anybody, we've had police officers give us names of patients that potentially could use service. There's a great community impact team down there that, I meet with the police in the emergency room quarterly, and we talk about, what can we do for this particular person. And,
I see,
sometimes referrals come from that sort of a direction.
Right. And so it's all ages.
It is now.
Yeah. Sometimes homeless.
Sometimes homeless. What is really hard and really challenging for us is that even if a homeless person, truly homeless, they're living out in the woods, is on Mass Health will not reimburse us to see that person because they do not have a physical address.
So it's one of those bureaucratic.
It's rather challenging. So we do try to be at the shelter to be as immediately able to support somebody that is coming in from the streets, but that has been a challenge, and it's hopefully a project down the road that I can work on addressing with Mass Health.
So I'm kind of hearing from you, it's like, and I recognize that too, that there's like, when you're dealing with these agencies, sometimes there's like check boxes, and it's like, oh, you don't have that, you're in the woods, you can't come here, and then it's like they fall into this, they fall between the cracks. So you're trying to prevent people from falling between the cracks.
Exactly. We don't want them falling through the cracks, and we certainly, they can tend to go in and the high utilizer is what the term now is. They go to the hospital a lot, but they either leave AMA or their needs don't get met, and so they don't go back when they really do need to. So what we'd like to do is be able to help figure out what are those needs and what is their perception of those needs, and then, using those soft hands, get them in the direction of care that really can make a difference. Can
you talk a little bit about that, like in general, the needs that they would have and the needs that you would help them with?
Sure. I just thinking about some of the patients we work with, when they first come to us, it's generally, their meds aren't well managed, they're seeing 4 or 5 different doctors, but really they don't have food, and that's all they care about. And so sometimes just kind of closing those doors for them, or, you know, getting them what they feel their survival needs are at the moment, and which is completely warranted, allows them to relax enough to open up to us, to say, yeah, really, I've actually had this pain in my back for a really long time, and I'd like to know what it really is about.
I see.
Now we can peel an onion and get those appointments. Our nurses will even do telehealth visits with them. With the whole COVID thing, it was kind of hard for our patients to see their doctors, because a lot of them don't even have phones.
Right.
So just kind of putting those pieces together for them, and really allowing for what their perceived needs are to be met, so that we can maybe get down to helping them stay stable in the community, get rehoused, and become healthier.
Okay. How many employees do you have here at your Hyannis office?
So the agency has spread down to Fall River, and we have a total of 140. Actively working in the office on a given day is somewhere between 12 and 14 for field support staff. Field support staff.
And then you have other people out in the field? Okay, and how many people are out in the field? Or is that top secret?
We have about 100 nurses.
Yeah,
and we have about, I want to say, 25 therapists at this point.
I gotcha.
And then we have, you know, our home health aides and our administrative support. We have clinical management, obviously, but most of our clinical managers are also out in the field seeing patients.
Okay.
You know, it's twofold. It's one, because I feel like it's important that they do the same work as the people that they're managing, to actually understand what takes, but also it's out of necessity. You know, we're a mass health driven agency. We're not, you know, a Medicare driven, and you know, we run at cost. And so they have to do visits. So it helps the agency financially to make that happen. That is huge. What we try to do is create more jobs out in the community by giving more responsibility to LPNs and RNs to do QA as a part of their job. So we then don't have to hire another person that isn't seeing patients.
QA is like the
quality assurance and
one-on-one supervision type of thing?
We do have field supervisors out there, but they're also actively seeing patients as nurses.
And they're all out here in the Hyannis, greater Hyannis area?
No, we're all the way from P-Town to Fall River.
Oh, so you cover the whole area here.
Yeah, we do. We're
so
a little bit into Plymouth.
Altogether, how much personnel is like wrapped up in this mission that you guys have?
We have 140 personnel.
Altogether?
Altogether.
Just in the Cape all the way down
to Fall River.
Fall River, wow. Wow.
Yeah.
That's a big agency.
It is.
And you're
pretty quickly.
And you're the one that's the director of the entire agency?
Yeah.
Wow. Wow. So, when you were younger, you know, back elementary school, is this where you thought you were going? What did you want to be when you were younger?
I wanted to be a doctor when I was younger.
You did? So
I did. Yeah. I knew there was a calling medically for me, but I never visualized this would be what I did.
Yeah.
You know, I loved being a paramedic when I was younger. That was great.
What'd you love about that?
It was exciting. It was adrenaline. I actually worked on what we call the teddy bear truck, the pediatric, trauma truck. I love the discipline. Certainly the hands-on, managing a trauma, managing a code.
Mm-hmm.
It was very fulfilling, very satisfying.
Yeah.
So.
And getting back to this, do you like being the director of such a big organization, or would you rather be right out in the field with the hands-on stuff? Do you miss that?
I think I do miss it to a certain degree. The coach in me wants to coach everyone, but as we've grown, I've had to train my coaches, so to speak.
Mm-hmm.
And I think it was a challenge to me to let go of not being the person who interviews and hires everyone, not being the person who trains everyone. And it wasn't, it didn't really impact me until, COVID hit, and we had, there was no one here. There was no one in Hyannis, but I was here every day for 2 or 3 months because I wanted someone here at the office for the field staff who never stopped doing their job. Mm-hmm. And we do about 2,500 visits a week, so gloves and masks and gowns and the logistics of all that were really important. But just realizing that we had dispersed and sent everyone home, and everyone was working from home, taking care of the people out in the field, we never skipped a beat. We never missed anything. Our staff was completely taken care of. No one actually ever got COVID. Our nurses stayed healthy, you know, and it was easier for me to let go of not being micromanaging and be able to actually now start focusing on the other programs I'd like to see this agency do, like the pediatrics we just got going. You know, I feel more confident now that I'm not overburdening my managers. They love what they do, and they want me to, you know, move on to the next set of programs, and it's a great evolution, you know, and so it never really feels like work here.
Not work. No.
No, it doesn't.
That's great.
It doesn't.
I like to hear that. 25 years on the Cape, you said?
Might be a little bit more now.
Do you have a family here?
My sister and her family are here in West Barnstable. My niece and nephew are 29 and 25 now. Just the joys of my life, Erica and Billy. My father's in Mashpee with my stepmom, and my mom actually lives in Pompano Beach with her husband, so I have extended family, obviously, but my immediate family is here.
Okay. Any, are you in here for the long haul, you think? Do you see yourself going other places? You think?
Oh, for the job?
Yeah.
Oh, I'm not going anywhere else.
Not going anywhere?
No.
Not even if they said, hey, you can fly in a helicopter and do that or whatever? There's nothing else that's on your list of things?
No. I have figured out how to actually work in such a way that it doesn't feel like work, and create a team around me of like-minded, like-souled individuals. We always say the universe has brought us all together and keeps bringing more people like us into this fold. That, you know, we laugh together, we cry together, we help patients climb mountains together, you know. And so I would say most of us, we're lifers here.
Yeah.
Personally, I am. So. Yeah.
And the people that come here, do you have they tend to stay? You got a good
we have
retention
very
rate?
low turnover.
Wow, I can
really
see
good
why.
retention rate.
I can see why. Yeah. So this is kind of like a lifestyle for you too. It's like a.
I think so.
Yeah.
Yeah.
Yeah. It's like you're calling.
Yeah. Sometimes I have to look at the clock and go, "Geesh, I should go home."
Yeah.
So.
I mean, it's like. You're like the Mother Teresa of this outfit, right?
Oh, we don't need to use words like that. No. No, I think that I'm a good head coach.
But you obviously put yourself in there. I'm telling you, I can tell. You know, so really amazing stuff. Okay, so just talking a little bit more as a Cape Codder in general. What do you think are the major challenges of living here in Hyannis or anywhere on the Cape that you found out by living here yourself?
I don't know. It depends on which perspective you're coming from.
No, just dive right in.
Sheesh, I don't know.
There's no right or wrong answer here.
There isn't. I don't know. I think that there's a lot of disparity in social classes, and I think it goes unnoticed and unspoken about, and certainly then summer comes along and changes everything. And I think that unless you really do this work, your understanding and your attitude towards our patients who are underserved and whose needs aren't met it's very different. You know, I don't know that I don't know that my focus would be in any place else. You know, at least it hasn't been for the last 5 years. So the other challenges I think that the Cape brings us, other than traffic, which I mean that's a sign of, you know, good economic, you know, bursts.
Growing,
So we really shouldn't complain about that, even though it might take me 5 minutes longer to get home. I don't really have any other challenges personally.
It's not Bangkok, Thailand.
No, it's not.
Not even close.
No, not at all.
It could be a lot worse.
Yeah.
So how does somebody get to get involved in your mission if they're like watching this and they're like, wow, that's something I want to help out like she's doing? What would they need to do to get involved in an agency, your agency or an agency like that?
Right, yeah, so we're always looking for new staff. We have what we call evergreen positions that are always posted. We have an amazing social media platform at this point. We have
Are they entry level, or do they have to have a certain background, or does
So yeah,
both?
it depends on the role that we're trying to fill. Certainly, we are open to, and I would welcome anybody who is even interested in doing the work we do to come in and at least talk to us. It's not the easiest thing to get people interested in working in psych or addiction or homeless, and so, and not to say every one of our patients is homeless, but it sometimes scares other people, but those words don't even come into our conversations, and it's really rewarding. And when we have people come in who might be interested and aren't sure what we do, generally they walk out of here intrigued and want to learn more. So I would welcome anybody to just, give us a call. We have a website. Go to our website.
What's the website?
It is reliefhhs.com.
Okay.
There's a lot of information on there. I think we've created an employment, careers page on there, and if not, our phone number's on there. Even just calling and asking for an interview or a meeting. We meet with a lot of other organizations on a regular basis, and sometimes that's a way for us to get our information out, or for us to meet other people who might want to do the kind of work we're doing, whether it's for us or for another agency or entity. The conversation's always open. The doors are always open.
Conversation's open. It sounds like it's not a check off the box type of situation. As it's kind of similar with the patients. I mean, talk to it. Maybe there's something a person might have something and not realize it that you might need.
Right. Exactly.
Right. But it's what do you think the most important personality trait someone has to have in order to do this type of work?
Compassion.
I could have filled that one in for you, I think. Very good. So we should talk to us again sometime.
Absolutely.
Maybe later on. I might have some more questions for you and stuff. And it's fascinating. I mean, we've been going on here, and it's the time's just flying by. And there's so many other questions that I have for you. But I just I know you got to get back to work. Here's the thing. I want to just leave you with one question. You're looking out at my readership, and they're usually young people, all the way up to my age, Cape Codders, all different types of backgrounds, and they're trying to figure out their way here on the Cape. And do you have any advice in general that you could offer them? I know that's an open question.
It is an open question. Get involved. Don't sit idle. There's plenty of organizations to volunteer with and volunteer for. There's plenty of ideas they can come up with on their own to do something to make a difference. And getting involved is certainly a good networking opportunity, but it's a way to actually do something that helps you feel good about life and what you're doing. Sitting idle is not a good thing. Certainly we've learned that, if not for anything else has come out of the last year with COVID. Sitting idle is not good for us.
Not good.
So I'd say get up and get involved.
Fair enough. Very good. Thank you, Michelle.
You're welcome. Thank you.
Very good.